Well, welcome everyone to the 27th Degree with Chris and Nancy, brought to you by 27 Degrees Consulting. So, this is part of our three-part medical wellness series. And today we're really privileged to have Dr. Sandy Pant with us. Dr. Pant has a very long list of accolades, and I'll briefly let you know where he is about his training in that. He is fellowship trained specialist in interventional and structural cardiology. He's board certified in internal medicine. He's a member of the American Heart Association, the American College of Cardiology, and the American Societies of Echocardiography and Nuclear Cardiology. He's contributed to over 100 journal articles, book chapters, and abstract and oral presentations, and he's served on the editorial boards of over a dozen professional publications. We're really privileged to have Dr. Pant as a cardiologist here in the Fall River community, and he comes to us today to talk about some new devices that are available and treatments for cardiovascular disease. So before we go on, tell us a little more about yourself.
Well, thank you so much for that kind introduction, Chris, and it's very nice to be here with you and Nancy. Thank you for this.
Great, we're glad to have you here.
Great, thank you. So before going into the professional life, I'm from Nepal. For people who do not know where that is, it's a small country full of mountains close to India. That's where I did most of the basic medical education. And then I moved to University of Arkansas, where I did my medical residency training. And then I moved to University of Louisville in Kentucky, where I stayed for my general cardiology training and all the advanced cardiology training. And then we moved to Fall River and Prima Care, and been here for close to 3 years now. And it's a great community to practice cardiology and great group of people to work with. So I'm with the Prima Care Cardiology office right now, and I also serve as the director of cardiac cath lab at St. Anne's Hospital, and we see office here, patient here in our office in Fall River, but we do see a lot of patients from the small towns around us, Swansea, Seekonk, Rehoboth, New Bedford, up to Taunton. And we provide service to our patients both at St. Anne's Hospital and Charlton Memorial Hospital.
So you've been all around the country. Now, what made you settle in the Fall River area?
Right, that's a great question. So when me and my wife were looking for a job, she was primary care physician trained, and I was cardiology trained. When we were looking for a job together, primary care really strike us as an impressive practice, in a sense that it is a multi-specialty group where providers across various specialties like cardiology, gastroenterology, lung specialists, vascular team, great group of primary care physicians like yourself come together and able to provide that comprehensive service to the patient under the same umbrella. So this was very impressive. It is a physician-run organization where we focus only on patient care. So when we came across such a great organization, we thought this is a fantastic opportunity for both of us to practice. So that's how we ended up in Prima Care.
And Dr. Pant's wife is in my practice.
Oh.
Dr. Manali.
Small world.
Yeah.
Dr. Manali's your wife?
Yes,
She's
I've been very
so
fortunate.
sweet.
Oh, thank you.
Oh.
Yeah, she's fabulous.
Yeah, she's great.
Well, that's very kind of you. Thank you.
Yeah, no, gosh, you have a great dynamic medical couple there.
Thank you.
So let me ask you something else. Like, my background's nursing, and we were always told that Fall River has a huge risk. The greater Fall River area is at huge risk for cardiovascular disease. So can you talk a little bit about what you see in this particular area, and if anything surprised you with that, and the lifestyle and what challenges that poses to you as a cardiac specialist?
Sure. So as I mentioned, most of my training was either down south or in the Midwest. So when we moved to Massachusetts, we had a little bit different picture of Massachusetts, and we thought the patient, in terms of their disease prevalence, will not be as bad as we see in some other parts of the country. But I think here we have predominantly Portuguese populations, great people, but again, they have their lifestyle, which the diet consists of a lot of fatty food, and not the most healthy lifestyle, I
Yeah,
would say.
yeah.
And that brings on a lot of cardiac diseases, a lot of chronic cardiac conditions that we see in everyday practice. And just to put it in a perspective, like how's the disease burden in the community or in the country for cardiovascular disease as a whole. For instance, flu kills about 60,000 people every year, give or take, like maybe 10,000 plus minus every year. And cardiovascular diseases kills about 600 plus thousand people every year. So that's almost 10 times higher than the flu. I think next to cardiovascular disease is probably like cancer related death, and then third will be road traffic accidents. So that's the data from CDC. So we can imagine how bad is the situation and how prevalent is the diseases, and especially in this community, Fall River, where we do not have the
Sure.
most healthy lifestyle in the
Yeah,
diet.
we have a lot of diabetes too. I mean, we're one of the highest concentrations of diabetics in the country too, which I'm sure you're aware of.
Correct.
We're either second or third highest in the country, the Fall River, New Bedford area. So I think everything also flows down from there to some extent. You know, a lot of diabetics will have a higher risk of heart disease, and you know, we certainly have our more than our share of diabetics in this community. But you're right. There's probably some genetic factors. The lifestyle, as far as diet and all of that, is certainly a factor. I would think down south with all the chicken fried steak, heart disease would be higher, but
Right. Right.
but it's pretty high up here.
It is very high. There's no question about that. Yes.
So then, given that population, like we're certainly at risk, it sounds like, right? So what are the most common problems that you see in your practice right now?
Right. So the most common. So I specialize in diagnosing and treating cardiovascular diseases like blockages in the arteries of the heart and putting a new valve, heart valve replacement through minimally invasive catheter-based techniques. So that's my area of expertise in. The coronary blockages are blockages in the arteries of the heart. These are still one of the most common cardiac problems we have in this community, and that's related to their comorbid medical conditions, their diet, their lifestyles, and their family history. A lot of genetic component to that as well. So that's my main area of expertise.
If we have listeners out there that don't have a medical background, can we talk about what causes a blockage and what that means? I know you have some show and tell apparatus on the table.
Right. So I
But
can,
like what does that exactly mean when you're talking?
Sure. So this is basically our arteries are like in the heart are like the tubes like this for our audiences. I'm going to point this tube towards you, and maybe you can see how the hole looks like in the center. And this is basically like a plumbing pipes. It's a plumbing system of the heart, how the heart muscles get blood supply. And over time, when there's problems like cholesterol problem, diabetes, high blood pressure, smoking, family history, we have this cholesterol plaque deposits inside the arteries of the heart. And you see all these yellow plaque developing inside the arteries of the heart. When they grow in size bigger and bigger, they can compromise the blood flow, blood circulation to the heart, and we call it ischemic heart disease. That's when the patients have symptoms like chest pain, we call it angina, shortness of breath, and things like that. And sometimes these plaques can rupture, and they can create a massive heart attack, and patient can suddenly die because of this problem. So this is what the plaque looks like inside the artery, and these are the main causes for patients to have symptoms such as chest pain, angina, and also massive heart attack.
So when
Right.
someone starts feeling symptoms, is it usually like at this stage, like when it's really
Correct. So most of the time when the plaque builds up, they grow in size, and most of the plaque, which are 40 and 50% in severity, they may not cause symptoms, but they are a marker that there is a lot of diseases going on in the background. Hey, it's time to do everything we can to prevent it from progressing further. But when it grows further and further, 70% or more, it starts causing compromised blood flow to the heart. But sometimes it may, instead of growing, it may even rupture before it gets to a very severe point. And when it ruptures, they have a lot of clot formation inside and can shut down the vessel completely at that point. And that can 100% occlude the vessel that way. And that can put patient at very high risk for sudden cardiac death.
So a good point you made is that a lot of times patients don't feel anything until they get to about a 70% occlusion. I used to do a lot of stress testing way back a long time ago, And that would be something we'd always discuss with patients, that the test is not 100%. And if you have a small level of blockage, it's often negative, in fact. And someone can exercise and have a normal stress test, which is always, I think is interesting. Patients don't understand that sometimes.
Right.
So, I mean, the key is, I guess, to all of this, you want to really prevent it, and before you get to that 70% or greater occlusion, or God forbid, a rupture of a plaque where you have an acute heart attack. So what can patients do to prevent this from occurring?
And to piggyback on that question, like if I'm at 65%, can I get better, or am I going to be at 65% and hold
Will
my
it
breath?
regress, in other words, is
Yes.
what you're
Yes,
asking?
thank you. Will it
yes.
regress?
That's a great question, Ian. I'm a little bit embarrassed to say that our preventive cardiology, or preventive aspect of the cardiology, is still not the strongest. We focus so much on the treatment of the disease,
Right.
diagnosis of the disease, but in terms of preventive cardiology, we are still not as optimal as we like to be. And I always tell my friends that right now the country does not need cardiologists like myself, but what it needs really is the cardiologists who specialize in
Yeah.
preventive aspect of
Yeah.
cardiology. But we do have a great group of people at Prima Care who's got great interest and their expertise in preventive cardiology. We have a doctor who's trained up in Boston, Dr. Mendieta, who came down. His area of focus is preventive cardiology. We got Dr. Ramsey, Dr. Kidway, Dr. Chandler. And in terms of risk management and how we can prevent this from progressing further, I think it takes a lot of time and understanding of the comorbid conditions, assessing their genetic risk, and some of the disease do run in the
Right,
family,
sure.
the management of cholesterol, and nowadays we have the capability to understand the cholesterol part even extensively. We call it advanced lipid testing. So all these possibilities we have, and come up with an individualized plan, because every patient is different, their risk profile is different, their family history is different. So we cannot have one size fit all approach. But if we have this preventive cardiology clinic, patient can come to, and they can discuss about their individualized risk and kind of come up with a comprehensive plan tailored to that particular patient. And now coming to your question, Nancy, can it be regressed? There has been some data from Cleveland. If you're on a strict vegetarian diet and cholesterol, all the risk factors strictly controlled, there has been some data with ultrasound catheter inside the artery that plaque can be potentially regressed, but that takes a lot of commitment from both provider as well as the patient side.
And probably a lot of time, too.
A lot of time, yes.
Right.
Yes, that's correct.
So now, if I get into trouble, now even though I'm in nursing, I am the biggest scaredy cat ever. So, I know I'm in trouble. Going into the ER, I have been told, "Oh my God, you have blockages, and now it's time for intervention." Like, what's all this stuff that you have on the table here?
Right, so we can show you the blockages and how that can be performed. So it came, the history of the interventional cardiology, which specializes in catheter-based minimally invasive way of cleaning up the blockages and putting the stent. That technology had changed dramatically over the last 30 years. The first of those procedure was performed in late 1970s at Emory by a guy by name Andrea Grunzig. And at that time, the only thing he had was a balloon trying to open up the blockages,
Yeah.
and it may or may not stay open for a long time.
Right.
And then the stent technology came to the market in 1980s, and the idea there was to not only open it up one time, but how to stay open for a prolonged period of time. And that was 1980s. In 1990s, for the first time, that procedure was found to be very effective and better than just the medical therapy or putting someone on a clotbuster medication if they have a heart attack, which carries a huge bleeding risk
Right.
for the patient. And then we had a lot of centers established. We call it angioplasty centers like St. Anne's Hospital or Charlton Hospital, where patient can go if they have a heart attack. They have 24/7 services for this kind of patients. And that happened in 1990s, believe it or not. It does not have a very long history. In 2000 we had a new kind of stent came to the market. It's a drug-eluting, a drug-coated stent. The idea there was to keep the stent patent for a long time because we started understanding how the stent feels, and we are trying to come up with a technology where the stent longevity or patency can be maintained for a very, very long time. and that happened in 2000. And this 30 years or 40 years time frame was understanding the blockages in the arteries of the heart, how to open them up, how to keep them open for a long time, and how to provide a safe procedure for the patient. So coming to your question regarding, I'm scared, what does that entail? It's a minimally invasive technique. We go through the veins, or blood vessels or arteries in the groin. And most of the time nowadays we go through the wrist, and the risk of any major complications like dying or things like that is less than 1%.
Oh my gosh.
And most of the patient tolerate it very well. It takes about an hour or so to perform this procedure, depending on the complexity of the procedure. And most of the time, the patient are able to go home either late same day or next day.
That's great.
You know, it's amazing. I remember when I first started practice back in the 90s. Back then, it's amazing how this has all changed. I mean, back then, patients were getting angioplasty without stents.
Right.
And then I remember bare metal stents came into play.
Right.
And then it was the drug-eluting stents. And way back in the 90s, if you had coronary artery disease, although people were getting stented, a lot of those patients ended up having coronary bypass and surgery.
Correct.
And now you very rarely see someone have cardiac surgery for coronary artery disease. You see it sometimes, certainly, bad disease, it's multi-vessel. But even with these interventions, I see that the cardiologists are doing multi-vessel disease now, where before that was more the area of the surgeon's work. So,
Right. As the stent technology getting better and better, a lot of times we're able to offer very good results, long-term, long-lasting results with the stent. And many patients are now reluctant to go through major open heart surgery because of the surgical risk.
But it is remarkable how this has just advanced so much in just a short period of time. 20, 30 years is really not that long in the history of the world, but there's been amazing improvements in this technology.
How long do the stents last for?
So that's a very good questions. And there are two ways the stent fail, and we can, if we understand how they fail, we'll understand how long they last for. I think the stent fail either by forming a clot inside the stent, which we do not see it often. This incidence is maybe about 0.5%, and that has to do with the medication non-compliance mainly. And the second mechanism is forming a scar tissue inside the stent. And that is a predominant mechanism how stent fail nowadays. And as I just discussed, in 2000, when this drug-eluting stent came to the market, so they have this chemo drug coated on the stent. They have something called polymer that carries the chemo drug in the stent, and that prevents the scar tissue from forming inside the stent. The stent failure rate for now, for our the newest generation drug-eluting, we're in third generation of drug-eluting stent now, is about 5 to 6% in the first year. That's the highest risk. And the patients whose stent fail are people who have bad diabetes, who smoke a lot, or on dialysis because of kidney problems. These are the patients where the stent we see failure in the first year. And if they go past the first year, there's about 1% per year rate of stent failure.
Yes, not
so
bad.
pretty good odds of having that open, keeping that open for a long time.
Yeah, that's fabulous.
Now, once you're called in for intervention, do you follow the patients yourself with the patients that you deal with?
Correct. So we have, and again, this is where Prima Care, I think, in my opinion, is a great place to practice, because there's such a great continuity of the care. Immediately after the procedure, I follow the patient, and when they get released from the hospital, we can talk. We have this platform where we can talk to each other. It's a technology, a digital technology, something like WhatsApp or messenger system through which we talk to each other, and we call the primary care physician, we call the cardiologist, and tell them that this is what we found, and this is what the risk factors for the patients are. This is what needs to be addressed, so that there's a great continuity of care for these patients after they get released from the hospital.
How do you
Great.
check on the stent and the effectiveness, like to know if something's not going as planned?
Right, so that's another great question. So back in the days, again in 1980s and even in 1990s, when the stent technology was not the best and the failure rate was very high, patient used to be back to the heart catheterization lab and then check out those stents with the dye test.
Right.
But nowadays, with such a great stent technology, we do not have the need to do that. So that's good for the patient. Now, if they have, we call it symptom-based strategy. If they have problem like chest pain or shortness of breath, especially when they exert themselves, And that's when the patient knows that something is not right. And that's when we bring them back for either checking out the stent or performing some other test like either CT scan or stress test and things like that to find out if they need to be brought back to the cardiac cath lab again.
I guess one of my questions would be if I run into problems and I have to have this intervention, now I have a stent, how much can I stress my heart after that?
That's another great question. So the stent from the stent standpoint, after they have a heart attack, that's a different patient than somebody who comes in, from the office and gets the stent done and goes home the next day. So after having a heart attack, we like the patients to go to the cardiac rehabilitation program, which is a very exciting program where patients, it's not just the exercise, it's a graded exercise program where the heart is monitored very closely to kind of find out how much the heart can handle and slowly ramp up. That way patient's heart is not under too much of stress. And once the patient is through the cardiac rehabilitation program, we get a data on how much patient can do when they are in, for example, stage 1 of the exercise or stage 2 of the exercise. That will help us make a determination how much they can do afterwards. But for most of the patients who are electively come to the cardiac cath lab and get the stent done, able to go home the next day and perform most of the activities of daily living by next day, and maybe back to completely normal activities in a week or so.
That's amazing,
That's great.
isn't it?
Yeah, it really is.
Oh my God. Remember like when they were in a hospital for a week for just like some like minimal thing
I know.
25 years ago? And it's like now it's like, okay, we're
mean,
going to
there's-
go fiddle around with your heart and you're going to go home.
Right.
Just think about like cataract surgery years ago.
Yeah.
People would have to lie flat for
Right.
Now,
days.
The weights and everything.
And
yeah.
now it's they're in and out and it's done. It's just there's been so many great advances. So you look like you have some interesting things here. Do you want to show us what you
Correct.
got?
Yes, so I'll show you. So before we show you some of the valve technology, so as we discussed, the plumbing problem was one of the number one in terms of cardiovascular, the prevalence of the cardiac diseases. And up to 2010 and 11, that was the main focus of the entire cardiology field, where people focused on how to take care of the blockage in the arteries of the heart, how to take care of patients with massive heart attacks. And now 2010, something really interesting happened in the field of cardiology. So that was for the first time clinical studies were conducted when patients who have entirely different heart disease called heart valve disease, those can be taken care of without the need for open heart surgery.
Yeah, it's amazing.
Again, go to the groin, the vessels in the groin, all the way to the heart, put a new valve in and come out, patients able to go home the next day, able to walk around, perform activities of daily living.
Incredible.
Yeah, so 2010, I think that's a change in their entire field of cardiology, revolutionary change in the field of cardiology, where they opened up a floodgate for a different kind of technology. We call it structural heart interventions, and that's what my expertise is. So we can talk about a little bit about valve diseases, and also show you like how the heart valve procedures are performed.
Yeah.
So.
What percentage of valve disease is congenital?
Yes, it's a great questions. There are a lot of valve disease that could be congenital, and the front valve, the side valve, they can have problems like prolapse or born with some kind of valve which is not normal looking valve. They can be congenital, but in our experience, the most common reason why this valve fails is again age-related calcific degenerative process in the heart valves, and that's how they fail. And I can show you, for example, for the front valve with this one here.
Okay.
So this is how the front valve of the heart looks like normally for our audience here.
Okay.
So that's the aortic wheel.
This is the aortic valve. So this is your heart, and the heart is connected to this big tube that carries the blood to all over your body. And between this heart and the big tube, there's a valve, there's a connection. It's called aortic valve. So valves are basically like the structures that opens and let the blood flow in one direction. They opens up like this, let the blood flow in one direction, and then closes. Do not let the blood leak back into the same chamber. Okay. That's the purpose of the heart valve here. And normally that's how the heart valve looks like in the front, the aortic valve. When it opens up widely. So if you put your finger through this, Nancy, this is how a pliable, a good-looking aortic valve looks like. It's very easy to open up that valve.
Squishy.
Now, as we grow old, we deposit a lot of calcium in this valve. And this is now how this aortic valve disease, we call it aortic stenosis, looks like. It's all calcified. Now, if you want to put your finger through this one here, it is tough to, very tough to open up that valve. And this is how the aortic stenosis looks like in the patients. So If you look at the prevalence of this aortic valve disease, about 500,000 population has severe aortic stenosis. And it is a lot to do with the calcification process in the heart and some degree of genetic component, some abnormality in the valve itself that they're born with. Um,
And part of that is just aging, you said?
a lot of it has to do with the aging, but part of it is also how they're born with. Some people, instead of born with 3 cusps in the valve, they're born with 2 cusps, and those valves fail earlier than other people. So there is some genetic component to that for sure, but a lot of it has to do with the aging process.
So your heart valve would look a lot different than Chris's. That's sad.
I think mine's healthy. I'm hoping. Maybe I should go get an echocardiogram done at some point. I don't know.
Yeah, we can pick up a lot of this heart valve disease with the echocardiogram.
But I mean, it is amazing. I see a lot of bicuspid valves. You know,
Right.
these genetic two-leaf valves too, and they, of course, they will degrade quicker. But it's amazing when I think back to treatments that we had before 10 years ago.
Right.
For this, you would have to. I mean, a lot of times you would really wait because it was really such a big ordeal to go through surgery. Open your chest, put a new
Correct.
valve in, and there's a high risk of mortality, death, and people feel terrible after a while. So I remember in training in medical school, there was this. We'd always learn this mnemonic. I don't know if they still do this. ASH, angina, syncope, and heart failure. So
Correct.
basically 5 years out with aortic stenosis, you maybe start having some angina or chest pain because the heart's working harder and the blood flow needs are outstripped basically because the heart is working really hard to get that blood to the valve. And then 2 to 3 years before death, essentially, you might see people passing out because they have this narrow valve. And then when you get to 1 year, it's heart failure. It's kind of, at that point, it's really hard to do a lot, right?
Correct.
You wanted to. One of the things we always learned was when do you intervene, because it was such a big thing to intervene. But now I'm thinking you can probably intervene earlier.
Correct. So
Right?
that's a very interesting thought you have, Chris, because back in the days, again, when we did not have the technology, we have to weigh the risk and benefit of everything we do with the patient. So if you have to send somebody this, we discuss about how age-related process affects the heart, the calcification in the heart, and this elderly population, it is too much sometimes to put them through a massive surgical procedure, which
Right.
carries a significant risk, the morbidity as well as mortality for the patient. And those times we had to really weigh the risk and benefit.
Yeah.
Now we started catching this patient early, more and more early, so that we can provide the destination therapy before it's too late. But it's a very interesting data. If you look at the country, it's still only about 20% of this patient. We talk about how the prevalence of the disease, about 500,000 patients. Only 20% of the severe valve disease are treated. Even in the United States, we got
Why?
best healthcare in the world. We got the best technology in the world, but still only 20% of them are treated.
Why?
That's a great question. So I was in American College of Cardiology meeting during this pandemic era and tried to figure out how the access to the healthcare system can be improved and quality improvement talks like that. And one of the guys there, he kept going and said that because we rely so much on the testing, advanced testing, but we do not really examine the patient, listen to his chest. A lot of these patients do have a heart murmur, and maybe it is missed that way. That's why patients are not getting referred. And I got really offended by that
Right.
talk because my wife is a primary care physician, and I see her going to the office with her stethoscope. She examines the patient.
Sure.
So I told him that, hey, I have a first-hand experience. That what you told me just now is just not. It's very hard for me to digest. Maybe
Yeah.
there's some
Right.
people who may fall into that category, but you cannot generalize that
Not-
like that. And what he was really talking, I clarified with him later on, is during the COVID, the pandemic era, when you do the telemedicine visit, which is good for a lot of chronic conditions, but some of the heart conditions where you cannot examine the patient, it might be
Exactly.
tough. So that's what he was referring to. So he didn't mean to say that we do not examine the patient. So coming back to the reasons why those patients are 80% of patients still not treated is, number one, is complete misinterpretation of patient's symptoms. And our classical teaching was, as Chris just said, the chest pain, the angina, the shortness of breath, the congestive heart failure, fluid problem. These were the common symptoms of the aortic valve disease. But now we start learning more and more about this disease, and I get a lot of referral from the cardiologist about the so-called asymptomatic severe valve disease to my office, and the question is, Doc, what do you want to do with this patient? And when I start taking the history with this patient, I ask my
They're
first
not
question.
as asymptomatic.
Correct.
Exactly.
The first question I
Yeah.
ask them, Mr. So and so, how do you spend your day? What do you do in a normal day?
Right,
And they
right.
tell me that, hey, they wake up in the morning and they fix their bed, fix their breakfast, walk
Yeah.
out their dog, go to the grocery store, hang out with their friends. And my second question is, are you able to perform these activities you were able to do last year or the year before with the same energy level, the same intensity? And they tell me that, Doc, I'm not 60, I'm 70. And that's when I get my answer. This is
Right.
people are trying to undermine their symptoms or attribute these symptoms to their normal aging process, which may or may
Right.
not be true.
Right.
Right.
And this may be a sign of the aortic severe
So a lot
aortic
of it
valve
just
disease.
to do is with the
Yeah.
screening.
Well, I think,
Right.
you know,
Yeah.
the other thing is, of course, these conditions, they progress over a very long period of time. So like you
Right.
say, patients just attribute it to other things, normal aging. But when
Right.
you really delve into the history, like you say, you realize they're really very limited.
It's
Right.
probably like patients don't want to think they're sick either, so they'll
Right.
justify everything.
Correct.
You know,
Right.
Especially
I-
the men.
I
They
think so
try to
too.
undermine their symptoms.
Yeah, we do.
Yeah.
We're a little simple that way. But you know, but you know, we
So-
see this with other conditions like COPD and that too. When you
Correct.
really, you know, really get into it, people can be a lot more limited than you know if you do a cursory history. But you
Right.
find out that they get up in the morning and they basically are sitting in the chair and watching TV, and that's the level of their activity, and it's slowly declined over a period of years. So.
Right.
Dr. Pan, it doesn't have anything to do with insurances and coverage, does it? Like, is this like cutting edge, or is this accepted and covered by insurances?
Right, it is a cutting edge now, and it is covered by most of the insurance company now. We hardly ever see any trouble with the insurance coverage. But I think a lot of that also has to do with how we digest or how we adopt the new technology, because a lot of old school doctors are still
Yes.
do not have understanding of this technology. That's why they are still holding on to the patient, thinking
Yeah.
that they do not have much other options, so they are not aware of the technology, or they do not know how it is important to timely refer this patient.
Yeah.
Because there's a good data, at least on aortic valve disease, that if you do not do anything to a patient who has severe symptomatic aortic valve disease,
Right.
in 2 years, 50% of them either die or require
Yeah.
emergent valve therapy, which is never a happy
No.
situation. To do something like this emergently without procedural planning is never a happy situation. So if you compare that to any other disease,
Right.
like a widespread metastatic lung cancer, it carries similar kind of horrible prognosis. So this
Yeah.
timely referral to the specialty center is very important in that regard.
I think akin to what you're saying. I remember, you know, the older way of doing it was that you would try to balance when the risk of doing the procedure, which was an open procedure at that point, evened out with, you know, the risk of them dying. You know, you try to find where that crossed on a curve. And you didn't want to get to the point where the heart was damaged, as you say, because once
Right.
that happens, it's hard to really get good functional recovery back afterwards. But with this, I think the key is you got to refer earlier.
Correct.
You know, so we can't think like we used to think with aortic stenosis, narrowing of the aortic valve.
Right.
You know, these patients need to be referred earlier so they can be followed by a cardiologist, and they can probably get the procedure done at an earlier time
Sure.
before there's any damage whatsoever to the heart.
Sure.
Right.
This is how the heart valve will look like. So I'm going to pull up this heart valve. This is for the aortic valve. And this whole, the crown is what anchors the valve in place. And this is a leaflet from inside. It is made of cow pericardium, which is the membrane covering of the heart, in a cow heart. And we have pig valve, we have cow valve. These are a category of valve. We call it a bioprosthetic valve, which does not require strong blood thinner, commitment to strong blood thinner for the patient. And this is how the valve looks like. And I can show you exactly where it stays in the patient's heart. So again, this is the heart. It sits in my body like this, and these big tubes, they go all the way up to the groin area, all the way down to the feet, and they connect all the way up here to the heart. And we go from the vessels in the groin area all the way up here like this. And once we come down this pathway, this valve is usually mounted in a balloon, we expand the balloon, and this valve, the crown anchors this in place, and there's a leaflet on inside which is kind of protected from inside, and that opens up like a normal valve. And we come out with this delivery system. We put sutures in the vessels we go through in the groin, and most of the time, Nancy, we don't even require general anesthesia for this procedure.
Oh, I would. I'm just telling you.
Yeah, if I need it, please knock me out completely if I need it. But,
Can I please?
Sure.
but when
So
you're
what are you doing? Like, what do they get if they're not getting general anesthesia?
So we call it a conscious sedation, where patients are, I know a lot of patients have this perception that if I'm not under deep sleep, I may have pain. But either way, patient not going to feel any pain. The reason I prefer no general anesthesia is because their recovery is quicker, and a lot of elderly patients, they have some general anesthesia related complications, like retain the urine afterwards, things like that can happen.
Yep.
So that technology is available. It's ultimately the decision from
is
from
it
the
similar to
patient.
what a colonoscopy?
Correct,
So
exactly.
it's the same
Heart
type of thing.
catheterization procedure, colonoscopy, a lot of this minimal invasive procedure can be
propofol
performed.
and
Correct.
that type of thing. So,
Right.
and when you do have that stuff, you don't remember anything, which is great.
Correct.
You're breathing without a tube down your throat, of course, but you're not conscious enough to know what's going on, which is a wonderful thing with a colonoscopy, certainly.
Right.
And with this, I'm sure too. But is it this big when you deploy it?
It is not in the model.
Okay.
It is big, but in actual heart valve, it is not as big as this.
Because you're going through the groin, so how big is the actual device that you're pushing through the artery in the groin?
So it is, when we started again, we had a big devices. It's almost like a garden hose, but the technology again since 2010 had changed so much, and this is the third generation of the valve.
Okay.
And this can be we go through a smaller tube, much smaller tube. We gauge it by a French size, and it's about 14 French. When it started, it was over 20 French.
So it's like a pinky
So
almost.
it is, almost like a pinky, yes.
Okay.
Almost like a pinky.
That's not too bad.
Yeah, that's not bad. And then we do a lot of CT scan, a lot of testing beforehand to make sure the vessels are big enough to be able to carry that pinky. And most of the 5.5 or 6 millimeter blood vessels, it can easily handle the 14 French seat size.
What's that other contraption?
Yes, so that one will show about a different kind of technology. The Watchman will talk about atrial fibrillation.
Oh, that's a great procedure, the Watchman.
Correct.
That's been a game changer also.
Yes. So this is before I forget about the valve technology. So every valve technology, this is another very interesting concept that has came into practice and is really a standard of care. It's called heart team approach. So heart team approach is really like whenever I see a patient with a heart valve disease, I do all this testing, and then I don't make a decision right away for the patient. We all sit down together every week.
That's so great.
Right. We have a group of doctors who sit down in this meeting. We call it a heart valve meeting. We have a doctor like myself, structural heart disease specialist. We have primary care physicians
great.
like yourself. We have cardiologists. We have heart surgeon, anesthesia doctor, research nurse. We have a team of people who look at the data together. And we come up with the best plan for the patient.
That's great.
Procedural planning for the
Oh,
patient.
yeah. As a patient, that makes me feel so good because
Yeah,
I feel like I'm getting studied by a team of experts.
Correct. So when you meet me, I tell you that, Nancy, maybe this is what you need. You already have your first, second, and third opinion right there
Yeah, that's perfect.
by different specialties.
So you had said a couple of times, you had mentioned like Boston and stuff. Is there any reason I would have to go to Boston?
So no. So the only reason we have referred a patient to Boston nowadays is for procedure or surgery like heart transplantations,
I see.
which we do not have a heart transplantation
Yeah,
technology, or some of the complex valve repair in patients who are born with abnormal kind of valves. So
It's really those extreme cases.
So
Yeah.
my referral to Boston is way too less than 1%. Right
Yeah,
now.
I don't
That's great.
remember the last time I sent someone up to Boston for a cardiac issue, where years back it was fairly normal.
Yeah.
Right.
Particularly before there was a cardiac surgery program, and these other types of interventions were commonly done. So
Right.
now it's almost never.
Right.
So what's this
So
Watchman
that's
thing?
the other technology we have now. There's a different problem. We could talk about the plumbing problem. We talk about the valve problem. Now there's a different problem in the heart, the electrical problem of the heart called atrial fibrillation.
Okay.
So just to put it in a perspective again, the prevalence of this disease right now is about 6 million population. Out of 330 million population in the United States, 6 million people living with atrial fibrillation.
Yeah.
And that may just be a tip of the iceberg.
Yeah.
And there's a good projection modeling data by 2050, atrial fibrillation is going to be the most common cardiac conditions. and it is going to surpass every other cardiac disease in terms of its prevalence. It's going to be over 50 million people with atrial fibrillation. So atrial
Why?
fibrillation is, yes, that's a great question, is because it has to do with the aging population, the baby boomers. It has to do with the risk factors and the huge pandemic of obesity.
Yeah.
So a lot of these risk factors, these are may not directly
I'm
be
gonna
the
check my
problem.
pulse, make sure I'm in a regular. It's pretty regular right now. Good. Okay.
Now we have the technology like iWatch.
Yeah.
Also, patients are using nowadays more and more commonly to identify this abnormal rhythm.
Yeah.
So it is an abnormal rhythm that comes from the top chamber of the heart. So every time heart, instead of squeezing like this, at least the top chamber, it fibrillates like this every now and then. The good news about atrial fibrillation, unlike some other rhythm problems, it does not instantly kill you. It's not those kind of rhythms
Right.
which will make you unstable unless you have some other problems in the
Yeah.
heart, like a different pathways for conduction. Then it can make you unstable. Most of the time, it's not unstable causing rhythm, the bad news is it puts you at a very high risk of a stroke. And elderly people 70, 80 plus, if they have one stroke, their life, yes, you have provided service to a lot of patients in nursing home too. You see them. If they have a stroke, that's the most feared complication. My father had a stroke, and I had first-hand experience, just not the medical care, but also their psychological thought process and their depression associated with it.
It's really a difficult condition for patients to to psychologically overcome. And I think that the strokes I see from atrial fibrillation, which thankfully we don't see as many anymore, they're not little strokes either.
Correct.
They're
It's
big
large,
strokes.
very large
They're really
strokes.
large strokes. So it's not these little what we call TIAs or small mini strokes. They're large and they're really devastating. So it's good that we can prevent them.
Right, and now for many years, the blood thinner was the solution for this
Right.
patient,
Right.
and you have massive experience with the Coumadin,
Right.
the Coumadin clinic, and Coumadin been with us for many, many years now.
Yeah.
But the problem with the Coumadin, all our patients know what the problem with the Coumadin is. You have to check your levels. There's so much of drug-food interaction, drug-drug interaction.
Sure.
So
It's a real problem.
Some people say that the cure cannot be worse than the problem itself, and Coumadin is unfortunately one of them where it is not easy to
Comes
manage.
close.
It takes a lot of commitment from both provider
does.
as well as the patient to
Right.
be on Coumadin. And this new kind of blood thinner pills came to the market to overcome some of the problem with the Coumadin. Like the new blood thinners, you don't have to check the levels, for example.
Like Xarelto and
Correct,
those-
Eliquis and things like
Eliquis,
that.
Sure.
And you also do not have as much of a drug-food interaction or less, really minimal drug-drug interaction. So these are all good things, more expensive medications. But there's one common theme among all these blood thinners. The way they work is by thinning out your blood. And it is just not possible to have a blood thinner pill which does not have a bleeding side effect.
Right.
It's just not how they work.
Right.
And when people run into bleeding side effects, for example, some nursing home patient, if they have frequent falls, they'll be very concerned,
Sure.
being on a long-term blood thinner pills like that. If somebody has ulcer in the stomach or diverticulosis or vascular malformations. I had a recent patient who had a retinal hemorrhage, the bleeding in the back of the eyes, and he could not see out of one eye. He went to the eye doctor, had the retinal surgery done and able to restore some vision. But he's now very concerned that he does not want to have that happen in his next eye and that he'll be completely blind. So
Sure,
those kind
that's
of
a terrible
patient,
thing.
yes, and at the same time, he didn't want to get any stroke because of the atrial fibrillation. So this is when this technology comes handy. So the way this technology works, it's called Watchman. And the Watchman, what really it is everybody in their heart has this structure called appendage. And this is the appendage for our listeners here. Let's see here. Maybe we can show it this way. This is the appendage. So this is a structure that hangs off the left top chamber of the heart. It's really like this earlobe here. Everybody has appendage. Nancy, you have appendage. I have appendage. Chris has appendage. And again, people who have a normal heart rhythm, it's not a problem because, as I explained, every time heart beats, squeezes blood in and out, there's no way clot can form there. But some people who have atrial fibrillation, when the heart does not squeezes every beat, it kind of fibrillates. Clot can form, especially in the structure called appendage. 90% of the time, people with atrial fibrillation, clot forms in this structure called appendage, and that can go to the brain and cause a massive stroke, as we discussed. Now, what we do is, again, this vein it goes all the way down to the legs, and we go through the veins in the groin all the way up to the heart. We cross from right side of the heart to the left side of the heart, and plug this appendage completely with this umbrella-like device. it actually looks somewhat like a parachute, like a device, and that prevents the blood from going into the appendage or clot from coming out of the appendage. So it takes about 6 weeks for body to heal this completely. Patient obviously can go home the next day, but the body healing is just laying the membrane over this device. So they need the blood thinner pill for up to 6 weeks after this procedure.
Okay.
But most of the time, after 6 weeks, they do not have to take the blood thinner pills, and this provides equal protection from the stroke, like any good blood thinner pill, without the need for the blood thinner,
Without the risk of
So-
bleeding.
without the risk of the bleeding.
So what happens to, so you're off the blood thinner, so you still have the potential, your body's still going to form the clots. Is this catching the clots? Like,
No,
what is-
because this
how does it
membrane here,
prevent it?
like a parachute, this membrane here. So
Yeah.
that membrane prevents the blood from flowing in. So now you do not have the blood going in there. If you don't have blood, you do not have a clot.
Yeah, yeah.
And if there's any clot left over here, it cannot come out because it traps the clot completely. Called this is PTFE membrane. So this membrane prevents any clot from
So it just
coming
stops
out
it
or stops it completely. And again, when the technology started, it got approved in 2015 by Food and Drug Administration, and now we have a newer generation of this technology. Really, the risk of major complication less than 1%. I feel pretty confident offering to this technology to our patient.
Oh, yeah.
And most of the time, patient goes home 99% of the time the next day, and able to conduct all the activities of daily living the next day, and don't have to worry about the blood thinner.
That's like crazy good.
It's,
Yeah.
That's
it's
like,
amazing
yeah.
that we're doing this technology right here in our local community. It really is. It's wonderful.
I can show you how exactly this Watchman, the real Watchman, looks like. So this is how it looks like. So this is, I call it umbrella device
my
for the
gosh.
patients to make them easier to understand. It really looks like a parachute.
Yeah, it
Actually.
does.
Yeah,
It's incredible what we can do now, huh?
great.
That we impact like the quality of so many lives.
Oh, absolutely impacts the
Yeah.
quality of life, and also a lot of morbidity associated with the blood thinners.
I mean, just like psychologically, if you know you're on Coumadin, you're going to stay away from
Yes.
certain activities and everything
Right,
else.
right.
Correct.
Especially, oh, nice, Chris. You're trying out the parachute thing, is that it? But that's great because then you can just do what you want to do, and
Right.
you're not like it's not on your mind all the time.
Right. Now I'm going to show you
Can I
one.
ask you something
Sure.
too? So we see, you had mentioned obesity, and that's kind of one side of the spectrum. But on the other side of the spectrum, we have a lot of extreme sporting now, and I've heard some things, some cardiac concerns with people that are doing all the extreme sports. So does any of this fall into?
Right. So extreme of anything is one thing I've learned is extreme of anything is not good, and we think that extreme of exercise may be beneficial to the heart, but that's not really the case. People who have extreme exercises, they have a lot of changes in their heart. We call it athlete's heart, and there's some evidence that they also have some increased risk of heart arrhythmia as well. So extreme of anything is not good for the heart either. They have very thick heart muscles, and there's some genetic conditions of the heart where you should not actually go for extreme exercise, extreme sports, like hypertrophic cardiomyopathy is one of them, which carries the risk of sudden cardiac death.
These words just roll right off your tongue. If I had to say that, I'd have to like go a little bit slower. You're just like,
But as far as exercise, I mean, walking is fine.
oh, all the moderate
You
stuff.
know,
Walking,
yeah.
American Heart Association actually recommends now over all the other exercises, daily walking 30 minutes every day, at least 5 days a week. That's the best thing. you can
And
do
that's
for
what I
your heart.
do. And I've gotten away from, jogging and other things because there's too much impact on the joints. And that's what I tell my patients. They say, oh, I can't go to the gym now. The gyms are closed, this and that. Go out for a walk.
Yeah, I see walking during your lunchtime.
I do it every
With your
day.
Patients.
Every
Yes.
day.
Yeah,
Yeah.
that's
Yeah, you're
great.
good with that.
That's
Chris.
fantastic thing you
Yeah.
can do.
Yeah, we're doing that for years.
Right.
What do you got here?
So this is the monitoring device. This is called a loop recorder. So this is another monitoring tool. So a lot of patients, as we discussed, the problem with the atrial fibrillation is the stroke. And atrial fibrillation, you may not have atrial fibrillation all the time. They comes and go. They tend to hide from us all the time. That's why we call it paroxysmal atrial fibrillation. They may not stay on all the time. So they come to doctor's office, we obtain an EKG, they're completely normal. They go home, tonight they can have atrial fibrillation. So, for many years we did not have a good monitoring system for these patients try to find out how best we can make a diagnosis of atrial fibrillation. We can catch it.
Right.
And for many years we did not have a tool, but now we do have this technology called loop recorder, which goes underneath the skin right here.
Right.
And it can record everything that goes in your heart for up to 2 years, or sometimes even longer.
It's amazing.
So if you have atrial fibrillation, say tonight, even without your knowledge, our office gets this data.
Yeah.
We know that you had atrial fibrillation last night. You may not know, nobody knows, but we'll know in our office because it's all connected through the Bluetooth technology. The transmission system works in our office, so we check that every day. And even before patient tells us that, hey, I felt something, we call them and saying that, hey, did you feel anything last night? Did you have these symptoms last night? And then, can you come over to the office? We have something else to discuss with them. And they come over. And atrial fibrillation also causes a lot of silent infarct. So first time presentation with a stroke, 3 or 4 months later, we found that patient had atrial fibrillation.
Yeah.
So that can easily miss if you did not have a technology like this.
So that's almost like a high-tech Holter monitor.
Well, it is a very high-tech
It's
Holter
so
monitor.
much better though than what we used to have.
Because it's not reliant on the patient.
Well, you know, I mean,
really with
just
the
thinking
event
about it, I
monitoring.
mean, this is what we, used to do would be someone had a concern about an arrhythmia, maybe they passed out, or like you say, they had a stroke. You do either a Holter or a 30-day monitor, and those things were a hassle.
Right.
Because no one liked to wear those things
Yes.
for 30 days. I mean, this just kind of sits under their skin and for 2 years, and they don't even know
Right.
that it's really there. And you put this in right in the office.
In the office, takes about 5 minutes to do them. It is very low risk procedure. I haven't seen any complications. I'll not say it cannot happen.
Where do they have to be placed?
Underneath the skin here
I
on
don't
the
know
left
if
side
everyone
of
can
the
see
chest.
this, but this thing is really tiny. I mean,
Right.
it's remarkable.
It is great monitoring technology we have in our office. Most of our providers offer these services to our patient and really help make the diagnosis of atrial fibrillation.
So if I know, if there's listeners out there that are thinking, I know I could be living a healthier lifestyle and I know I have some risk factors. Besides just the testing that they usually get annually from their primary care physician, I mean, is there some kind of baseline testing? Or, I mean, I feel like, geez, I kind of want to be checked out and see how far I am away from this stuff,
Right. Well, there are a lot of testing now available to understand your risk profile better. And every patient is, again, unique. And their risk profile, their genetic predisposition is unique. So we cannot have a one-size-fits-all approach. But as I explained to you, we have people in our group who are expertise in preventive aspect of cardiology, and if you talk to them, they can, sit down with you, assess your risk. We call it risk stratification for any kind of heart disease, and come up with a plan that can help mitigate your risk. So we do have that preventive aspect of cardiology service offered in our office too.
Now, if you had to, I'm looking at the time. I can't believe we've.
I know.
It's like I
I
just
wanna
want to
keep
talk to you
going,
for like
but
another hour.
We're probably going to wrap it up soon, but
I
we could
know.
go for another hour here. It's been great.
Before we break, I'm going to show you one more
Sure.
tool we
Okay.
have in our toolbox, and that can really help our patient mainly with the stroke prevention. And as we are talking more and more about heart disease, we also understand that as a advanced cardiac specialist, our focus not only in the cardiac disease, but also a lot of cardiac problems can cause things like stroke. And we do have expertise in management, co-management of the patient with a stroke, how to prevent it from happening again. And this technology, this is called a PFO occluder. If somebody has a hole in the heart, this is how the device looks like. And some people who have a stroke, especially younger patients, they may have a hole in the heart where, if you think about how the heart and the lungs function, we do have small clot form in our veins all the time. And lungs is not only an organ to oxygenate blood, but it's a great filter. It traps a lot of clots. So when the blood goes to the lungs, it oxygenates, it traps a lot of things from the blood circulations and send only a pure blood to the heart. That's what lungs does. But sometimes if you have a hole in the heart, that can bypass the lungs. The blood or small clot can go from right to the left side of the heart, which is directly connected to the brain.
How am I getting a hole in my heart?
Well, it's between the left and right chambers. So usually, it's something
I
you're
born with
with.
that?
Yeah, you're born with it.
Correct.
Okay.
1/3 of the people are born with the hole in the heart, and about 80% of those patients, it does not cause any problem. But some patients, it might cause stroke, especially younger patients with stroke, and that's one of the testing we do in our cardiac testing office to do echocardiogram with special bubble test to find out where exactly is the hole, and if they have a hole, this can help plug that hole completely. Again, we go to the veins in the groin. Takes about a couple of hours to do them, and with the camera we look at where the hole is at and completely seal off that hole with this device. Again, patient can go home the next day and goes back to work next day potentially.
That's great. Fabulous. So what's on the horizon for new things in cardiology?
Correct. So the cardiology, again, the 2010 to this date is really the booming in this technology or by industry about the structural heart disease or heart valve interventions, and we have been able to provide very good results with this front valve, but there's a valve on the side that's called a mitral valve, and the reason how this why this mitral valve fails is most common mechanism is leakiness in this valve, and we do have some technology to be able to take care of this leakiness, but we do not have a new valve per se for this left side. So that the field right now is heading towards how to develop a safe new valve that can be put in this left side of the heart without the need for open heart surgery.
Amazing.
So that's one really new technology coming up. And in a big picture, the next new thing that's going to happen to the cardiology field is this whole field of genetic cardiology. So I think, in my opinion, next 50 years, I'll be out of business, because when this gene technology comes into practice, you can cure these diseases at a genetic level. I'm sure a lot of work needs to be done.
Sure.
It has a lot of medical, legal implications as well.
Yep.
But cardiologists like myself will be out of business. But Nancy, I'll be happy to be out of business. If it's good for our patients, good for everybody, I'll find another job.
You know, that's okay, because Dr. Manali can work a little bit harder.
Yes.
And
I'll
you
be
can,
stay-at-home husband.
there you
I'll be
go.
happy to do
We'll
that.
bring you on
So-
as a primary care
There you
doc
go.
when it comes to that
I
point,
got two
all right?
kids. I love to spend time with them. So,
All right.
So how many of these devices can you have? Like, can one person have all of this stuff?
well, if they have a lot of diseases, but I do not expect one person to have everything goes wrong in their heart. And if they do, yes, that is a
I
possibility.
think they need a heart transplant.
Correct.
Checking if it's all compatible, you know?
Right.
Oh my
Well, this has
gosh.
been wonderful. I think we're out of time. We're actually over, but we could have talked for another
I know.
hour
I was
here.
so surprised when I
So
looked
much
at the
things
time. I'm
happen.
like,
There's
whoa.
just so much in the world of cardiology. We want to thank you very, very
Sure.
much
Thank you
for
for having
coming forward and sharing your wisdom with us and showing our viewers some of these new technologies, which are really fabulous. So if someone has an issue that they're concerned about, they should, I would think, go to their primary care doctor,
Correct.
and then they can be referred from there. If they wanted to contact your office directly, they could do that also, I
it's-
would assume.
Right, it's 508-679-9955, 508-679-9955. They can talk about the preventive cardiology. They can talk about their symptoms. They
Sure.
can say that, hey, I need to talk to the heart valve specialist. So that option is there if they call that number.
Fabulous.
Nice.
That's great. Any last words of wisdom you want to leave our viewers with?
The only thing I'll say with this pandemic going on, stay safe. Put your mask on all the time. Keep washing your hands.
Yep.
Do not go to the crowds and avoid the exposure as much as you
Yep.
can.
That's great.
Yep, until we
Thank
have a
you.
vaccine, which looks like it's going to be real soon.
Right. So we
So-
need to stay real strong this winter. Get
That's
through
right.
this winter safely.
Yep, very good.
That's awesome.
Well,
Thank you.
thank you. Thank you once again.
You're
This was
welcome.
really fabulous.
Thank you.
Appreciate it.